Alaikum. First of all, I would like to thank Dr.sheef for this invitation. Number two, we are pleasure to have Dr. Tariq Owaida with us today. Dr. Tariq, he is a consultant hematologist in King Faisal Specialist Hospital. He's going to speak today about the updated and antiphospholipid antibody syndromes. So we are very proud to have Dr. Owaida with us.
Assalamu alaikum. Good morning, everybody. It's my great pleasure and honor to be here in King Fahd Medical City and share colleagues the Symposium of VTE Prevention and Management. I had been preceded by two excellent talks, so I hope I can give you the same quality of talk. I've been asked to handle a difficult subject, antiphospholipid syndrome. And talking about diagnosis and management, it's a bit of a challenge. I hope I can take you through the journey of diagnosis and management of these difficult patients. We all know that in 1983, Professor Graham in London had described a disease that there is association between thrombosis, abortion, and cerebral disease with presence of lupus anticoagulants. And at that time, we didn't know about the antiphospholipid syndrome. Later, the Rheumatology Society and the Hematology Society decided to come up with a name for that syndrome called antiphospholipid syndrome. The syndrome is a clinico-pathological entity defined by two major components as being described by Graham in London early, which is the presence of at least one of the types of autoantibodies, and we will talk a little bit more about the types of antibodies, and that should be present with the one of the clinical features, which is either thrombosis or pregnancy failure. There are a couple of clinical presentation these patients may present with. Thrombosis comes up to the list. This thrombosis can be venous, arterial, or small vessels, or can be combined. The most common is DVT. Recurrence is a common feature of the thrombosis. Complications of pregnancy, which I will pass quickly, can happen early in the pregnancy, and it can present even with preeclampsia or abruptio placenta, or present as a pregnancy failure, and it is characterized by recurrence again. One of the catastrophic presentation is the catastrophic antiphospholipid syndrome, which characterized by a multi-organ failure. Other presentation including thrombocytopenia, skin lesions, hemolytic anemia, cardiac and pulmonary, all have been reported with different preferences. Talking about the antiphospholipid antibodies, or APA, which is quite important to know that initially WHO had reported lupus anticoagulant as the only antibody detected in these patients. Later, we came to know that anticardiolipin is another associated serum antibody that is present in either form, IgG or IgM, and these patients present with different levels of these antibodies. Later, another group of antibody, which is anti-beta-2 glycoprotein, had been introduced, which can be both detected by ELISA and added to the list for the antibodies. Yet, there are other antibodies, different antibodies like antiprothrombin, anti-anoxine, antiphosphatidylserine, serine, or antiphosphatidylate inositol. All these antibodies are implicated in the pathogenesis and the presence of antiphospholipid syndrome. As we all know that the common three groups, the ACA, lupus anticoagulant, and beta-2 glycoprotein, yet we know that there are evidence, and I'll go through quickly the evidence of presence of other antibodies that may implicate it in the diagnosis of antiphospholipid. The question, which is pathogenic? All had been detected in patients with antiphospholipid, but which one is really behind the disease of antiphospholipid syndrome? Clinically, one of the major questions we ask ourselves when we need to test for these antibodies. Should we test for every patient, or that we should restrict the testing for special group of patients? And the question being raised because we know if we go to blood donors or we go to the community and try to do a screening for these antibodies, we will find up to 5% of the population, or 8% in some of the literature, they may have or they have in their serum these antibodies. But how much significant these antibodies in the diagnosis of antiphospholipid? So the recommendation which has been raised by ACCB and the ISTH committees is you need to do these definitely for patients who present with unexplained prolonged ABTT, which usually get detected on routine checkup, especially pre-operation. Patients with thrombotic involvement of unusual sites, unexplained arterial or venous thrombosis, thrombosis in patients younger than 50 years, recurrent nature of the thrombosis. Patients with SLE, especially if they have additional symptoms like hemolytic anemia or thrombocytopenia. And definitely patients with abortion, and some even suggested to do the testing for infertility. I'll touch quickly about the types, the common types of antibodies. We know the lupus anticoagulants, which are the two broad categories of LA activity, depends on the presence of 2-GBI on the prothrombin. It is identified by a functional assay in the coagulation, and there are different types of assay. These assays have different specificity and sensitivity in detecting the lupus anticoagulants. And there are many factors that may affect either upgrade the detection or underestimate the detection of lupus anticoagulants, including the presence of some anticoagulants like warfarin. The LA association with thrombosis had been shown long time, and in two big studies, one of them we had conducted locally, we had documented that the LA is one of the most strong evidence-based or association with thrombosis, not like the anticardiolipin, not like the beta-2 glycoprotein. So if you get a patient with LA positive, the chance to get a thrombosis is much higher than those who are with ACA or beta-2. Testing for LA, because of its sensitivity and because of its crucial in the diagnosis of antiphospholipid syndrome, had been gone through three major guidelines. The ISTH published their guidelines in 1995 and then updated that in 2009. The British Society and the CLSI, International Society of Laboratory Medicine, again had raised some of the concerns and published their own guidelines. So that's all had been addressed in very extensive. As you can see, all these had been recommended before you do LA. So it's not an easy test. It's not an easy information, because the implication of this information is quite serious on the patient diagnosis and management. What about other antiphospholipid antibodies? We know these three, and these three already been incorporated in the Sabaro criteria, but there are concerns about some of the patients who typically present with clinical features of what looks like antiphospholipid syndrome, but we fail to document that they have antibodies. And recently, these group of patients been called as non-criteria antiphospholipid syndrome, because we don't have a causative antibody that will make us, or they become classified by the Sabaro criteria. Several studies had been done to evaluate different types of antibodies, like antiphosphatidylserine, antiprothrombin, and anoxin 5 and antiprothrombin antibodies. We had been involved in a couple of these studies, and the bottom line, which we can conclude out of most of these studies, that based on these data, that some of these antibodies had shown specificity and sensitivity, like phosphatidylserine, for example, more in detecting those cases where they were negative by other antibodies, which we had suggested for the ISTH committee to look more to incorporate them in the future as a possible antibodies that can be tested for patients with antiphospholipid syndrome. Classification, as you all know, had gone through various revisions. The first classification was published in Arthritis Rheumatology in 1999, which was the Sabaro criteria in Japan. And then in Sydney in 2006, this had been revised, where some more modification for the clinical definitions as well as for the laboratory definitions, including more precise estimation of the antibodies level, and increase the number of, or the interval between the revisiting or retesting these patients to avoid the false positive increase in these antibodies during acute phase period. I think there is a problem with, you don't see it there? Excuse me. Yeah, it's back now. Thank you. Let's go to the management of thrombosis in patients with antiphospholipid. As you all know, that not all patients with ABA develop symptoms. And as I had mentioned, even in the general population, if you test donors and general population for antiphospholipid, you may find up to 5% of the general population carrying the antibodies. But positive test with no manifestation is a puzzle, and we will talk a little bit about it. There is no direct evidence that the presence of the antibodies cause the disease. However, the presence of the antiphospholipid, the presence of the antibodies in context of the clinical manifestation is the one that makes the disease. The disease has waxing and waning because it's an immune-mediated phenomena, and patients with antiphospholipid more prone to reoccurrence. And there are many special situations. I don't think we will have time to look at all of them. But if I would like just to a snapshot on one of the things that been again published by ACCB addressing the relative risk of recurrence of VTE, and as you can see that the highest relative risk of recurrence is in antiphospholipid antibody syndrome. There are many questions if you have a patient with antiphospholipid and that patient develop thrombosis. And these questions raise up front and during the management, which I will try to go through it one by one, trying to explore what is the evidence based in the current literature. What type of antibodies, what type of anticoagulants you need to use if you have a patient with thrombosis? How long to monitor? What is the required intensity if you are using warfarin? And for how long is long enough to keep the patient on anticoagulation? The use of aspirin, the use of new oral anticoagulants, and the prophylaxis for primary versus secondary. We all know that the type of anticoagulant we use are different. We have unfractionated, we have low molecular, fonda, warfarin, and new oral anticoagulants. While the first three are monitored, they are anti-10 and monitored by anti-10 assays, there are different methodologies. And that's very important point because most of the people consider anti-10A method is the same for all anticoagulants measurements. This is not completely correct because although the test name is anti-10A, but the method used for detection of the anti-10A level is different based on the type of anticoagulants. And if you would like to measure the anti-10A effect on your patients, you need to provide the testing lab with the type of anticoagulant, otherwise you would be able to receive a wrong results. The anti-10 assay depends on the heparin type, the dose, the schedule. It needs to be picked in the peak at 3 to 4 hours, or you can do the trough at the end of before the next dose. Different levels been recommended by different societies, but the common is the one that's been published in the ISTH guidelines for therapeutic range for different types of anticoagulants. Once you finish from the period of parenteral iron, parenteral heparin, you need now to shift the patient to oral anticoagulants. And for a long time, we've been using warfarin as an oral anticoagulant. However, that has by itself a question about the intensity of warfarin. Early observational retrospective studies in 90s had suggested, because of the recurrent status of these disease, is to put these patients on high intensity, 3 to 4 INR. In the early of this millennium, 2003 and 2005, two major studies, randomized studies, mega ones, one from McMaster and one from London, both had shown that the standard intensity of 2 to 3 is quite equal to the 3 to 4, and by decreasing the intensity, you decrease the chance of bleeding barrier. So now the current recommendation, you need to keep the patient between 2 to 3 unless there is a treatment failure. So if the patient start to have a treatment failure, that means if the patient develops thrombosis while he or she is on 2 to 3 INR, you need to upgrade the INR 3.1 to 4, or you may add aspirin or another antiplatelet, or you may consider changing the anticoagulation because the warfarin became a failure. The duration is another important question, which is for how long we need to keep the patient. For patients who have the first episode of DVT, who have documented ABA, it is recommended to continue for 12 months, and that is grade 1C by ACCP. And maybe you consider indefinitely, and that is a grade 2C. And for the patients who develop the second episode, the risk-benefit of treatment with VKA for second episode should be measured. In a nice study published by Shulman in 1998, he definitely had shown a significant difference between those who received warfarin only for 1 year and those who extended the warfarin for up to 4 years. And you can see the accumulative incidence of recurrence was 20.7 in those who ended by 1 year compared to 2.6. For that, most of the people, except that for the second episode of VTE, you need to change the patient, put the patient for indefinite anticoagulation. How long is long enough? That's another question being raised by Professor Barandoni recently, and he challenged, should we keep the patient who presented at age of 20 years on lifelong anticoagulation with exposure to bleeding episodes? That's something we need to discuss, something we need to consider, especially if there is a risk-benefit issue about the bleeding for these patients. And he suggested that individual tailored and balanced against the hemorrhagic risk should be considered, and putting in consideration using tools like the D-dimers and ultrasound for estimation of the residual thrombus. The last thing, I think, because of the time, I would go in touch about NOACs in ABC. The new oral or the direct oral anticoagulants are emerging, and everybody is moving forward to replace warfarin with the new oral anticoagulants. Yet there are issues, and one of the issues with new oral anticoagulant is, should we use new oral anticoagulants for all patients regardless of the underlying cause? And one of the causes that had been discussed and raised is the NOACs for ABC, for antiphospholipid syndrome. There is no data up to date about the safety and efficacy of new oral anticoagulants in patients with ABS. And if we look at those clinical trials for which those new oral anticoagulants gain the approval from FDA, only 10% with ABS were included. So it's a small number. So it's hard to conclude the efficacy and safety on that 10%. ABL status was not systematically documented on all these patients, and there are currently phase 2 and phase 3 trials on rivaroxaban, 2 phase 2 and 1 phase 3 trials on rivaroxaban. They are open. The earliest one to finish in 2018. So we are waiting the answer regarding the safety of the anticoagulation with NOACs for these patients. And there is one study for evaxiban. From clinical experience and over the last 5 years where we had the exposure to NUX, in UK a cohort of 18 patients with ABS subjects where they received rivaroxaban and they proved safety and efficacy up to 12 months. In another study, 3 cases of thrombotic reoccurrence where switching from warfarin to rivaroxaban have been presented with thrombosis. And a couple of other studies, either in favor of using the NUACs for anticoagulation or against. Personally, I would be very cautious in patients with antiphospholipid. I would not switch them or start warfarin unless somebody else started NOACs for them. Then if they are on NOACs, I'll keep monitoring them closely, and if there is any suspicion of treatment failure, I will return them back to warfarin. I think because of the sake of the time, I would skip some of the other parts of the talk, and I will end by that one of the treatments modalities that been emerging now in the last few years is to use bone marrow transplantation for patients with antiphospholipid syndrome. And we had succeeded in transplanting 2 patients with antiphospholipid syndrome. Both of them, they had 17 thrombotic attacks. One of them had been published in the BMT Lupus BMT journal in 2011, where we managed to eliminate the antiphospholipid antibodies completely, and now for 6 years the patient is doing fine. There is tendency now to use the autologous bone marrow transplantation for patients with general autoimmune, and particularly for patients with antiphospholipid syndrome. I would like to stop here and thank you for listening.
Thank you, Tariq, for this excellent speech. So I would like to call the speaker and to start the panel discussions. So do we have any questions? So Dr.sheef. The mic.
I would like to thank all the speakers. A question directed to Dr. Tariq Owaida. Your personal experience about new oral anticoagulant in antiphospholipid syndrome with the triple positivity, because antiphospholipid syndrome patients are a heterogeneous group. As you know, they are single positive, dual or triple, and could be high titer. So do you have any selection criteria, individualized the NUACs for ABS patient, or you just use it generously? Okay.
Thank you. Personally, I'm very conservative for patients with antiphospholipid. Patients with antiphospholipid can be catastrophic, and if they start thrombosing, nothing would stop them from having different VTEs. So I keep patients with antiphospholipid on warfarin. But yet I have a couple of patients who've been started on rivaroxaban or new oral anticoagulants by somebody else, and they came to me. From my experience, I can say 50-50. There are people who they continue on rivaroxaban without any problem, and there are people who I had to switch them back to warfarin because there is a documentation. We cannot differentiate between treatment failure or compliance, because this is another issue. Maybe those who have a reoccurrence, they have poor compliance, and as you know, in opposite to warfarin, the new oral anticoagulant are short-acting. So if the patient misses a single dose, it exposes him to thrombosis. So it's really hard to differentiate, but I would be very conservative for putting patients on new oral anticoagulants until we have the results of the clinical trials which are going on.